Welcome to Empowering Plans, a show dedicated to identifying waste and undue expense in the health benefits industry, discovering ways to maximize benefits while minimizing costs, and empowering employers, administrators, and consultants to emphasize, once again, the benefit in benefit plan. Today's episode is brought to you by the FIA Group, empowering plans since 1999. Now here are your hosts, the FIA Group's own CEO, Adam Russo, and Senior Vice President and General Counsel, Ron Peck.
And Brady.
Good morning, good afternoon, good evening, good night. I don't know if the Truman Show has that copy written, but you are listening to another Empowering Plans podcast with the FIA Group. I am your Senior Vice President and General Counsel, Ron Peck, and with me is Brady Bizzarro. Brady, say hello.
Hello, Brady.
Did it again, man. It's literally
just hello. All right.
It's like muscle memory at this point, you know? But no, that's all right, Brady, because today you get to say and do whatever you want. You know why? Because this is your show today, Brady. We are talking politics. We're talking about the results of the elections. I got to tell you personally, for an election that didn't involve the presidential election, I feel like this election got more airtime, more media coverage. It was talked about by everybody. The amount of money that went into the campaigns. For something that wasn't a presidential election, so much attention paid to it. You must have just been in heaven, huh?
Yeah, I mean, and now we get to talk about it much more than we did on the webinar, so I can just go on for hours about this. But you're right, Ron, because actually I looked up the numbers before we started this podcast, and the spending for these midterms was historic. $2.6 billion in spending nationwide on all the campaigns. That's a crazy amount of money. It means that every second you are watching TV, you probably watched a political ad, and it's really crazy. And also, we're always in campaign season now, right? Because already 2020 is around the corner. And there's already super PACs forming, and people are making phone calls asking for money. I'm sure we'll see, people declaring, if not already, who's running, and I'm excited about that.
You know, I remember this was many, many years ago. I can't believe how long ago, actually, when they had the total recall in California, right? and they recalled the governor, and that was when Schwarzenegger was running. But you remember, it seemed like everybody was running for governor, right? You had porn stars and actors and singers and jugglers. It didn't matter. It was like a circus. And that was sort of California because that state seems bigger than life, right? It seems like Hollywood is real. It's everyone's personality there. I'm feeling like the next campaign is starting to get that same sort of feel as that California governor race, where I'm hearing about how, like, Stormy Daniels' attorney, who was just, I'm not going to say arrested, but let's say he was detained for domestic violence. They couldn't help but make note. And it was also rumored he'd be, casting his name into the ring, the hat into the ring for the presidential election. And there's the other, who is it? The gentleman who failed in his congressional race, I believe it's in West Virginia, this veteran who he unfortunately lost there, but this Democrat who I guess President Trump has called him, crazy or something like that. He's this ex-veteran. Yeah, and he's got the muscles and the tattoos, and he said, I'm going to run for president. It just seems like the cast of characters that are throwing their hats into the ring for the presidential election, I've never seen anything like it.
I think it's because sadly, but it's the way things are, it's good business to run for president, really. If you don't win, you can write a book, you can pull a Newt Gingrich or something, and you can stay in the limelight, and you actually can make money for running for president. That's why you see, I remember in 2008, in the lead up there, you had sort of 8 candidates from the Democratic Party running, 8 candidates on the Republican side, and you had all these lengthy debates. I mean, how many more podiums can they fit on these stages? We'll find out, I guess, but you could have like 16. I mean, how many people? I mean, I remember last election cycle, they had to sort of cut people out of the debates, but it's also good TV, and it's good ad revenue for the network. So I don't see this problem getting fixed anytime soon.
I'm not worried about podiums. I'm actually thinking the next debate, they're going to roll in remember Hollywood Squares, where everybody, they're sitting above each other and they're stacking them vertically. And,
that'll be great.
And they'll light up the square when it's your turn to speak. But, man, wow. It's great to be an American. So speaking of entertaining elections, it wasn't just the people that were running for office that dominated a lot of the airtime. The questions, the ballot questions that we were seeing in all the different states, those took up a lot of budget dollars as well. In Massachusetts alone, for instance, we had question 1. That's right. Of all the questions, it was the most important. That's why it was assigned number 1, right? I would argue my local fire department that was lobbying for budget dollars in question 4 was the most important. But, they got the money, by the way. We're going to be okay.
Okay.
Oh,
That's
yeah.
good.
Carbon monoxide, too. It's the whole 9 yards, cat up in the tree. But question 1 related to the provider, the nurse to patient ratio and the mandatory ratio by law. And I know we're going to talk a little bit about that question and some of the other ones across the nation that relate to healthcare, but this is just one example where a question regarding healthcare was on the ballot. A huge amount of money was spent, much more by one side than the other, and the side that spent the money won the day. And I think that we started to see that pattern elsewhere. And the other thing, and again, I know we'll talk a little bit greater detail as we start to delve into these different questions, but I think the overarching theme, as far as I could tell, was 1, you don't tell providers what to do. Hospitals, doctors, they know best. You can't issue laws that dictates what they can and can't do. You let them do their jobs. And I want more health care. I want as much health care as you can give me. Mandate coverage up and down, left and right. But don't tell me how it's going to be paid for, and certainly don't tell the doctors what they can and can't do. Sort of the I want it all, but I don't want you to come up with a plan to make it happen was sort of the theme of the day.
That's very American-like, I feel like.
It really is. I want more, but don't ask me to pay for it.
Yeah. It's funny you mentioned that, Ron, because I feel like a lot of pundits of this election, as they analyze the results and what they mean for healthcare, they've pointed out that this election was so nationwide focused. By that, I mean the media was so focused on national issues. And typically, politics is local, right? Tip O'Neill will tell you that. But there were some sneaky important ballot questions, and we'll get to them in a second. But I think it's helpful for us to let's just go over the state of things now. Where do we stand in the balance of power in Congress? Because that's going to matter next year and beyond for what does or doesn't pass legislatively related to healthcare. So the first thing to note, obviously, people heard about the blue wave coming. Wasn't quite what it turned out to be, but it's important to note that the Democrats did pick up about 33 House seats right now. I think one was just called in Maine today. There's still some outstanding, but the House is now flipped blue. And it's also important to note that this was not a historic landslide victory for the Democrats, right? In 2010, House Republicans and the Tea Party wave picked up like 60 seats. That's a lot. 30 seats is kind of standard. It's typical that the president's party loses seats here, but the turnout numbers are really good for Democrats. They won in the suburbs. They have a lot of new faces in the party that represent more diversity, more women candidates. That's going to help them down the line. And so I think there's a good chance that they keep the House for a while, in my view, especially with the census coming up in 2020 with, I think, a crackdown by courts on gerrymandering and on redistricting. I think the House will be some shade of blue for a while to come. That means we're going to have a Speaker of the House that is a Democrat, probably Nancy Pelosi, someone for whom the ACA is extremely important, someone for whom protecting people with pre-existing conditions is extremely important. And so I think you'll see her priorities will shine through in the upcoming Congress. That said, we have a divided Congress because the Senate stays red, and they picked up, it looks like at first they would pick up about 4 seats. Now it's probably going to be about 2 seats. The recount in Florida, I don't know what's going on there. Now I'm hearing about machines overheating, and I think the deadline's today by 3 p.m. There's always a nail biter there, but it looks like the Republican there, Rick Scott, who was the governor, is going to eke out and edge out, rather, Bill Nelson, who's been there forever. And you'll have a Republican seat there. An important state, by the way, upcoming in 2020 to have a Republican senator and governor from. So I think the numbers don't lie there in terms of the state houses, and that's important too. Republicans do still have an edge over Democrats, something like 33 to like 25. There's a couple independent governors. I didn't even know that those existed, by the way. But you have a lot of red state houses, and that's important because they will drive their agenda at the state level, and governors appoint insurance commissioners. So we'll be looking to see, if any big Democrats also want some states back. So we'll look and see who gets appointed where. But that's why state governorships are important because, especially with a gridlocked federal Congress, you're going to look to the states to maybe tackle problems like surprise medical billing, like air ambulance, things that Congress won't be able to do because they're deadlocked. I think will fall to the states to do. So these results matter.
Sure. And, a lot of the topics that we've been following here at Empowering Plans and our webinars and different industry associations relate back down to state law. What's interesting is, we talk about, self-funded plans, ERISA preemption of state law, and all the state stuff you're talking about, Brady, doesn't matter. It does matter. One great example being association health plans. We've been telling people that association health plans, great opportunity to dip your toe into self-funding. We've got employers banding together, but they have to comply with state law. So here, you may be someone who's promoting association health plans as a way to self-fund to employers who've never done so before. State laws are going to matter. The MEWA laws are going to matter. What happened in the state level is going to matter.
Yeah, and with AHPs in particular, I mean, we've had a number of our clients come to us say, hey, we want to form new AHPs under the new rules. What do we do? Where do we go? The regulations are final, but they're being challenged in the courts. And so I think what's going to happen now is I think we're going to see this process of the regulations being flushed out is going to be slowed down because with the Democratic House, they have the ability to call hearings, to stall things, to stall legislation, to challenge the administration on every front as they try to push for the expansion of AHPs and short-term plans. They have a subpoena power, so they're going to use it, and they're going to clog up at every opportunity they can any administration action, whether it's through executive order, which we've seen done in the past, or by promulgating regulations at the agency level. We'll see that going forward. I want to make a note quickly. We talked about spending in the beginning of this podcast, and one note I got from SIA here is that this cycle, SIA contributed $200,000, which is the most it ever has. That seems like not a lot compared to the hundreds of millions spent by big pharma. Oh, right, exactly. Or the providers.
Yep.
But for our industry, that's a lot of money, and it's money that's been raised by SIA members. It's important that we have that SIA is able to. Unfortunately, like it or not, money is involved here, and so money matters. And it's important to note that I think it's saying something that in this midterm cycle, it's the most they've ever donated. So you can see that number is probably gonna have to go up because there are a lot of issues like stop loss regulation that SIA is advocating on our behalf. And one of those issues is the Self-Insurance Protection Act, which a quick follow-up to that story is that last we heard, of course, SIA was instrumental in getting it passed in the House by an extremely large margin. I forget exactly the number. It was like 400 and something to 16. It was insane. But since then, it's sort of been stalled in the Senate, and I think SIA would like to see some kind of action in the lame duck session on that in the Senate. It's probably unlikely, though. And so I think what you'll see is because the Senate has stayed in Republican control, I think the same committee chairmen and committee chairwomen that they've been approaching, they're not changing either. So I think they'll know who to go to next year to try and get that bill pushed forward. For those of you listeners who don't recall what that's about, essentially that's a bill that would prevent states from redefining stop loss as health insurance and therefore prevent them from regulating stop loss in a burdensome way. So it's an important bill, but there's really no new update yet on that front, but it's something that I know is important to many people in the industry to mention.
I'm glad you brought that up, Brady. The fact that it did come through the House so overwhelmingly supported by really both sides of the aisle. I've actually been hearing a lot of talk online and on the radio about how when you have a lot of this back and forth control of Congress and the Senate and the House, and people start to feel a bit of, I don't want to say exhaustion, but they start to get a little wary of Washington, D.C. not being able to really get anything done. So the reason that you see a change, even if it's not that drastic, you do see a change is people say, I don't feel like enough is getting done. Let's make a change and see if that changes things. And I know that in the next 2 years to 4 years, as we start to see these elections come up again, a lot of the people who are currently sitting in those seats, they want to be able to point to some sort of, whether it's law, regulation, that they were able to accomplish in a way that really was a bi-party, it was something that everybody got support, that we were working together, we were able to get it done. There's this bipartisan support, even if it's low-hanging fruit. And my hope is that something like the Self-Insurance Protection Act is going to be something that they could look at and say, hey, look, we need to look good, you need to look good. Here's something we could just both agree on and be able to tell people, hey, look, we were working bipartisan, we got this passed. So maybe we can sneak it through sort of as one of those things that, hey guys, here's at least one thing we could agree on. Let's just get it out of the way and be able to point at it and give the thumbs up.
I think that's the right play, and it leads me to the next topic I wanted to bring up before we talk about these ballot questions in more depth, and that is, what are the areas to be hopeful about? What are the areas where we might see bipartisanship? You just mentioned, I think that's an easy one. SIPA, the Self-Insurance Protection Act, is a great place to start. But on top of that, I mentioned this in the webinar too, but I listened carefully to likely Speaker of the House Pelosi's victory speech, where she really had a conciliatory tone. She said, things like, we're tired of division, we're one country. She mentioned drug prices many times in her speech, and so has President Trump. We've been covering this extensively, where from his blueprint back in May to other actions he's proposed at the agency level, from banning the pharmacist gag rule, from requiring manufacturers to disclose prices in TV ads, which would be, super scary for them. But this is an area that all Americans and really all health plans agree there's a big problem here. Drug prices are just way too high. Everyone knows it. We've been talking about it for years, and I think this is a really, really important area. It could be an easy one to score a victory on. It's not going to be easy, but it's definitely an area. I know they're also working together, both parties, on criminal justice reform. So that's happening actually, I think, as we speak. There's developments there. But this is something that I think in the beginning of next year, drug pricing will be one. I also think surprise medical billing will be another, because both Republicans and Democrats think that's a problem. The question of what exactly to do about it might be difficult to iron out. There was a bipartisan bill that was introduced in the Senate that has some important names behind it, and I'll give you just a few of them. Senator Cassidy, Senator Grassley, who was the chairman of the Judiciary Committee, who will now be the chairman of the Senate Finance Committee. This bill basically says that providers will not be able to balance bill patients in certain situations. Like, if, for example, if they have an emergency and they find themselves out of network. The problem with this bill potentially for our industry is that one of the solutions it proposes is that the plan pays more. The plan pays something like 125%, not of Medicare, of some other amount based on geography. It's pretty unclear. So obviously that's probably not a solution that self-funded plans would like to see, but at least there's the beginnings of identifying in a bipartisan way that there's a problem here with balanced billing, and some states already have legislation in effect to combat this problem. But at the national level, if it's a bill that we can get behind, I think that would be a good thing to see going forward, because you wouldn't have to rely on 50 different states coming up with solutions to the problem of balanced billing. That's something to watch, I think, going forward in the future as well. Could be an easy area. Also, air ambulance billing. That's something that is probably not super high on the radar, although maybe it should be because of how crazy it can be. Those are areas in healthcare, and frankly, protections for those with pre-existing conditions. Both parties know that this is very popular in the electorate. People voted on this issue, on healthcare overall, but this was an important sub-issue for them. So that's the final area I think we'll see bipartisan support at the federal level.
All right. So we're going to keep our eyes on that. Now, forgetting the federal level, let's go back down to the state level. We talked a little bit about the question number 1 in Massachusetts and the nurse-to-patient ratio. How about California, the other side of the country?
Yeah, so they had an interesting one here about dialysis, and I'll be honest, I was surprised when I looked to see how much money was spent, and you mentioned how, certain measures were expensive. This one here, $130 million was spent primarily by the opposition to the bill, but what this would have, I should call it a measure, or really a referendum, wasn't really a bill, but what it was here, it was essentially, it would have capped dialysis clinics' reimbursement rates at 115% of the cost of direct patient care. And that's a defined term, as you might expect. Direct patient care meaning that you could only account for salaries and wages of staff who actually provide direct care to patients. So not management staff, not administrative staff, just people who are literally sitting down with patients administering the dialysis treatment, or doctors who are diagnosing certain conditions and whatnot. But if you were not furnishing care, you could not be counted in this 115 amount. Any amount above that would have to be returned by the dialysis companies to the payers each year. So that would have been a humongous change. Of course, what the companies claim is that this would lead to the closure of clinics. It would lead to dialysis patients not getting the care they need. And of course, California is humongous. As we've said earlier in the podcast, it has 68,000 dialysis patients, 600 dialysis clinics. It's huge. And so the state is burdened, not just employer-sponsored plans, but the state is burdened by the cost of dialysis. This, I think, was an attempt by the people of the state to try and get a handle on the expenses here. The unions, by the way, the hospital union that organized this referendum to begin with, was actually not only concerned with the cost of dialysis, but they're upset with just the quality of the clinics. There's some really crazy horror stories about clinics in California just being overrun with rats, with roaches. There was one story about a patient that was left and died in, I think it was California. A patient was left alone in one of these clinics and was found dead the next morning. Just gross neglect going on. And so they're really trying to put the spotlight on these clinics and on these dialysis providers, the biggest of them being Fresenius and DaVita. And so that measure, unfortunately, after tons of money poured into the state, was defeated, 61% to 38%. So pretty resoundingly, people said no. And I think if you ask me, based on what I've read and some of the articles about this, seem to suggest that people thought it was the wrong solution to the problem, that they were scared that this might actually be too much too soon, might lead to closures of clinics, might lead to sick patients not getting the care they need. It's the same kind of, I think, reason why question 1 in our state failed.
You know, during the last webinar that we did, which I believe is also posted online, if you weren't attending it live, please feel free to download it. We talked briefly about this question, and Adam, he brought up the fact that the rate at which they were willing to pay the facilities, the clinics, this 115% or whatever it is, he was arguing that number was too low. He was saying, even I, being Adam, I believe very strongly in saving money for the plans, and yet even I think that may be even too low. And so his feeling was that maybe the people who opposed it, maybe the people who voted against it, it was because they realized that particular number was too low. And I think it's great that he gives that kind of credit to people, that they were actually able to calculate it and determine, well, 150% would be fine based on gross domestic product.
Yeah.
These are not economists. Most people were voting. I think that any cap on charges, the people who were advertising and lobbying against this proposition would have made the same arguments, that it's not enough, you think it's bad now, just wait and see. And the people who voted were going to vote against it no matter what. So I think it's less about the number at which you set sort of the cap and more just about the fact that you're setting a cap in the first place. And I believe, and it is interesting, I believe the best way to maybe communicate to people about what's fair, what's reasonable, where we should set a cap, instead of just picking a number and saying, here it is, instead set some sort of a threshold based on parameters that people can get behind. Yeah. So basically you're saying, hey, look, I don't want to sort of say a Medicare-based or reference-based price, but just because it's for sake of argument, they could come out and say, hey, look, Medicare pays for most dialysis. And after doing much calculation, we've determined that the Medicare rate allows a clinic to make a profit. We think we should put a cap that's double Medicare. So think about how much profit that is. And if you communicate it that way, maybe people can understand. Because, again, when you pick an arbitrary number, people don't understand where that number came from. Automatically, you're going to think, hey, you're wronging the recipient. You're wronging the payee. But when you phrase it more as, look, it costs them 50% of what Medicare pays. Medicare's doubling their money. We're going to double down again. I think that maybe people could start to get behind that. But unfortunately, we haven't really, I think, engaged at that level with the voters. That being said, at least the conversation has started.
Yeah, and building off what you said, I think the other problem that Californians are facing here is that typically when you're talking about caps and percentage thresholds, that's a better forum to have that discussion in the legislature. So you propose a bill and say, how about 125? And then they say, well, how about 140? So you start low, if you're going to negotiate and compromise. But I think the reason that wasn't done in this case is you probably can't get that kind of a bill introduced in the state legislature because of the powerful interests involved. So I think that's why, and not just California, but in many states across the union, when you have these explosive ballot initiatives proposed, it's because it's an interest group going to the people to get the required number of signatures, and they're bypassing the stranglehold that interest groups have on the actual, state representatives. So you go into the people directly, and you're forced to put a certain number down on the ballot initiative, and that's what happened here. Because I think otherwise, I agree with what you're saying. You've got to convince people that this number either isn't arbitrary or isn't too adverse, or you have to be willing to change the number, and you can't change it on a ballot initiative. And I think the same thing happened in Massachusetts, where we had question 1, and just to give a little bit more background to those, For me, this was pretty interesting because I have a lot of friends, as you might guess, who are nurses. Actually, they're in touch with what's going on in hospitals in our state, and they were so evenly split over this question, which would have imposed a limit on nurse to patient ratios. I think it was one for every 5 patients, you'd have one nurse. Currently, there's only limits on these ratios in ICUs and intensive care units. They're not in ERs. That's the big one, by the way. They're not in surgical units. They're not in maternity wards or psych wards. And so nurses on one side were saying, look, we're being overworked. Patients are not getting the care they need. It's unfair to us. And on the other side, the opponents saying, well, this is going to increase wait times. It'll force hospitals to cut back on services. They may have to close. And the Wall Street Journal actually weighed in at a national level and said this would require the state to have hired 3,100 more full-time nurses, which would have been too expensive. So really good arguments on both sides here, and this was a tough question for people to vote on. The people that I talk to who usually, take the side of the worker here, but they really thought long and hard, and I mean, I had a hard time deciding how I would vote here. And at least initially when this was really catching attention statewide, this question, it seemed like it was close. And then something happened in the last couple of weeks, or the polling was just bad because it was defeated 70-30. And that's a pretty resounding defeat.
You know what I find so interesting about this, Brady? Let's say hypothetically there's a few restaurants downtown, right? And let's say one restaurant has a diner to server ratio of, 2 diners for every 1 server, right? Is there a line? No, right? Quick service, you sit down, they're right there at your table, they're feeding you, everything's great, right? The other restaurant, they have a server to diner ratio. They have 1 server working on 20 different tables, right? There's a line out the door because they can't get people fed fast enough. The service is terrible, right? And then there's one restaurant in the middle, and it falls somewhere in the middle, right? So maybe there's a bit of a wait, takes a little bit longer. The restaurant with more servers, guaranteed the cost is going to be higher, right? You're going to pay more to get that kind of service because ultimately the restaurant has to pay more servers. The restaurant with the 1 server, maybe it takes forever, but the cost of the food is bargain basement, right? The one in the middle, it straddles the fence on both sides. And then you as a consumer, you vote with your money, right? You say, look, I've got the money. I want to spend it. I don't want to have to wait, right? Or I don't have the money. I'm willing to wait a long time. Or you know what? That place right in the middle like Goldilocks is just right. But the point is, when you look at most other instances where you're being served by some sort of provider of a service to you as a consumer, you're aware of the situation and you make a conscious decision. No one's ever going to pass a ballot measure that says, we demand that every restaurant have at least 1 server for every 3 diners. And I find it fascinating that in healthcare and these hospitals, maybe one hospital is already meeting this standard on their own. They went out and they said, we don't want patients dying in the ER. We need to hire more nurses. And if we have to run up the bill, so be it. If we have to, figure out where to find the money elsewhere, so be it. And then another, they say, hey, let's push it as far as we can because we can't afford it or whatever the reason. I'm going to give people the benefit of the doubt. There's no malicious intent here. You as a consumer of healthcare, unless you know where to dig deep and find out, you don't know which hospital is which.
Right.
And so as a result, they have to say, look, there's no way that the consumer of healthcare, the patient, can determine which is the safe hospital and which is the dangerous hospital. So let's pass a law that forces them all to be safe. And I'm not saying that I'm not saying going out to dinner is the same as going into an emergency room, okay?
No,
I get it.
okay.
Listen, all right? I and my family have been through enough healthcare scares that I know the difference. But at that 30,000-foot level, it does fascinate me that in healthcare, it's the only place where you're paying for insurance, presumably as a private good. You're a consumer of healthcare like a customer, and yet the actual provision of healthcare is this very political, legal, regulated entity, almost unique to this industry compared to other industries.
Yeah, it's one of the most regulated industries, I think, probably in the world, really. And I think, like you said, it's because of the special status of healthcare. It's personal to everyone. It's very expensive. There's a lot of information asymmetry. We don't know the kind of care that we need. We just know when we show up at the hospital, we expect there's enough nurses there to, it's well staffed that we can get admitted when we need to, and we can get the care we need. And so I think, like I said about the California question here, many of the people the pundits who analyzed why this question went down in flames the way it did is because they think most people agree there is a problem with nurses being overworked. There is a problem with some large hospital systems, just stacking it up on, hey, nurse, work these doubles and triple shifts and take all these patients. But they didn't agree that this was a proper solution. And again, I think a bill introduced in the State House, you'd have the opportunity for public hearings and comment, experts to weigh in. You'd probably end up with a negotiation. But I'm not so sure you can get that kind of a question currently on, presented in the State House, given the lopsided power that providers in big hospital groups, especially in our state, have. And that's a sort of dismal outlook. It's a rock in a hard place for these questions. But I think eventually something's going to have to break through here. Something will, that's with respect to whether it's staffing ratios or, what's going to happen to the ACA or just the gridlock in Congress. If the feds don't figure it out and the state houses don't figure it out, people will figure it out. It'll eventually get resolved in some way, and we'll be here along for the ride for it, I think.
You know what I think is amazing, though, Brady? At the end of the day, what do these questions tell you? They tell you that people feel like the quality of the care is subpar,
right,
but the cost of care is too high.
Yeah.
We want more for less.
We're back to where we started. I think.
Isn't that what we've been saying, right? So if that's what you want, be sure to tune into our other podcasts and webinars to find out how to accomplish it without a vote.
Right.
So Brady, any closing thoughts?
Yeah, I mean, I'm excited. Like I said, I think unfortunately, like it or not, 2020 is in full swing. I fully expect healthcare to be on the ballot again in 2 years. I think next year we will see hopefully some bipartisan efforts to resolve some of the easy problems that were easy in the sense that we all agree that they are problems. And so I'm trying to be hopeful. That's a thought I want to leave our listening audience with.
You radiate optimism, Brady.
All right, thank you.
You bet. Either that or I'm still sensing Adam's presence. So on behalf of myself, Brady Bizzarro, Pat, our incredible producer, you're the man, Pat. Thank you for everything you do. Adam, who is on the road working on our behalves as usual, and the rest of the FIA group, our partners, clients, and friends. Thank you for tuning in and listening to the Empowering Plans podcast brought to you by the FIA group. Thank you.
Thank you.